Hi everyone. Thank you so much for joining us for day two of our GHPC conference. We are joined by Tom Davis from World Vision International, Abidayar from World Vision International, Svetlana from PATH, and Ellen and Aaron Pfeiffer from Global Consulting. They will be presenting for us today on exploring the impact of maternal mental health and its impact on child health and well-being. Please go ahead and take the floor, Aaron.
Great. So we'll go ahead and start the video.
Thank you, Tom. Welcome to this session, Exploring the Impact of Maternal Mental Health on Child Health and Wellbeing. My name is Erin Pfeiffer with Food for the Hungry and coordinator of the Caregiver Mental Health Knowledge Sharing Series. Maternal mental health is increasingly recognized around the globe as a critical component of women's well-being with long-lasting impact on her welfare, her family, and the health and development of her children. Our panel today will showcase 3 research case studies that add validity to the growing evidence base about the value of integrating mental health into traditional health, nutrition, and early childhood development programs. In the interest of time, these brief presentations will be consecutive, followed by interactive breakout rooms in which panelists and participants will explore together the barriers and opportunity for addressing caregiver mental health in development efforts.
Everyone, I am Abaida Orke, Interpersonal Psychotherapy Specialist from World Vision Ethiopia. I will speak focusing on maternal depression sub-study in rural Ethiopia. Many evidence has identified maternal depression as a potentially important determinant of child growth and development outcomes in low-income settings. World Vision Ethiopia, together with other 2 NGOs currently implementing maternal depression sub-study, which is a randomized controlled trial in rural Ethiopia. The sub-study is designed as part of Enhanced Nutrition Activities within Development Food Security Activity Program funded by USAID. The sub-study seeks to identify whether reducing maternal depression can support improvements in child development outcome and whether reducing maternal depression can enhance the effectiveness of other dimensions of Development Food Security Activity Program. Based on the midline survey conducted in the study area, the prevalence of maternal depression is close to 20%. The midline survey was also used to invite eligible women for group interpersonal psychotherapy treatment. Maternal depression was measured using the PHQ-9 screening tool, a survey-based tool that has been validated for use in Ethiopia and translated to local language. A cut of 8 and above was utilized to identify women eligible for the IPTG treatment. These cutoffs are based on the standard usage, but the literature is not definitive. Women who were severely depressed and having suicidal thoughts were also referred to hospitals for immediate psychiatric services. Group interpersonal psychotherapy, which is a 12-week depression treatment model, was used to treat those identified depressed women. The model has been empirically validated and can be applied at low cost. The model is also community-based and can be facilitated by trained lay people. 467 depressed women participated in the first round of interpersonal psychotherapy for group treatment. Life change-related stress is the major contributing factors of women depression as it is reported during screening. Most women attended the 12-week sessions as planned, and the average initial PHQ score was 11.61 and the end session score was 1.86. Child care practices also significantly improved at the end of the treatment as it is reported by women who attended the 12-week sessions. Post-treatment follow-up is done once a month for 6 consecutive months to track possible relapse. Impact of combining this intervention with other nutrition enhancements will be assessed along with several dimensions in the outcomes, like practice of improved infant and young child care practices, and the nutritional and the cognitive development outcomes of their children. Thank you.
Hello. From earlier studies, we know that depression can affect behavior change and hurt child growth, and interpersonal psychotherapy for groups, or IPTG, can rapidly reduce depression in developing countries. What we had not demonstrated was that this intervention to reduce depression, IPTG, can improve adoption of health, nutrition, and WASH behaviors that are associated with better child growth. So that's what we set out to determine in this study in Kitgum, Uganda, which was led by Food for the Hungry in collaboration with World Vision, Johns Hopkins, and Columbia Universities from 2016 to 2019. We first identified about 1,250 depressed women and organized them into clusters, which were care group service areas, all the women reached by a single care group of about 12 volunteers. Then we randomly assigned each cluster of women to the treatment or comparison arm. The initially depressed women in the treatment group first received IPTG treatment for about 3 months, and then behavior promotion through care groups for the remainder of the study, about 15 months. The initially depressed women in the comparison group only received the care group behavior promotion for about 15 months after a 3-month waiting period. And note that when both groups of initially depressed women received the care group intervention, they were doing so alongside of other non-depressed women and those neighbor women groups. IPTG is a methodology that's been approved by the WHO, and with IPTG, an IPTG promoter, who is usually not a psychologist, is trained for about 10 days in the IPTG methodology, and then meets with groups of about 8 depressed people weekly for about 3 months. With IPTG, you encourage the depressed person to regain control of their mood and functioning. So following the 3 months of IPTG treatment, we found that the 625 depressed women who were treated with IPTG had a greater reduction in depression than those in the comparison arm who did not, which was not surprising. We also found that the depressed women who received IPTG treatment had significantly higher adoption of 1/3, or about 4 out of the 12, health, nutrition, and WASH behaviors that we promoted, the circled ones on this graph, than the untreated women. This is after the IPTG treatment and even before behaviors were promoted through the care groups. The adoption of these behaviors was 23 to 32% better on average in the treatment group, or about 7 to 13 percentage points better, as shown in the table on the right. We also found that women who were still depressed after IPTG treatment across both arms had not adopted any of these behaviors. However, this is not the whole story. The difference in depression between the initially depressed then treated women and the initially depressed but not treated women attenuated after those depressed women were reached in care groups. By the end of the study, both groups were nearly depression-free, and both the women who were treated and the women who were still depressed after treatment caught up in terms of behavioral adoption by inline. This was quite surprising to our academic partners at Hopkins and Columbia. Women who only received the care group behavior change intervention had a decrease in depression of about 95% by 21 months post-baseline. The researchers on our team agreed that this may represent a strong therapeutic effect of the behavior change intervention itself, the care groups, and it may be due in part to behavioral activation and increased social support. Thank you.
Screening and counseling or group therapy for maternal depression is gradually becoming a part of partner-supported community interventions across the world. However, what about making it a part of routine health services, especially for the mothers who have recently given birth? In Mozambique, integrated management of neonatal and childhood illnesses mentions the need to check mothers for signs of depression and offer counseling. PATH has worked with the mental health department at the Ministry of Health to develop and pilot the first ever protocol for screening and counseling for depression as a part of routine postnatal consultations. The nurses in 8 primary healthcare facilities were trained and mentored to use PHQ-9 for screening and adapted WHO's Thinking Healthy cards for counseling. Operational evaluation 1 year after the pilot demonstrated that the nurses perceived screening and counseling as feasible and easy to do within a routine consultation. Even more importantly, the nurses perceived these activities to be among their core tasks. Effective support channels were established by pairing nurses with mental health providers who acted as mentors and supervisors, and who were motivated by increasing referrals from the nurses. With regard to detection, the nurses identified depressive symptoms in over 3% of the mothers they saw 2 weeks after birth, which is a recommended screening time. A similar study in Mozambique, but done with trained data collectors and outside of consultation context, resulted in 9% detection rate. Several factors might explain this difference in detection. These include the amount of training the nurses received, which might have been insufficient, lack of privacy in many consultation rooms, the need to build rapport with the mothers, which were not used to being asked about their mental health in a routine consultation, and finally the difficulty that many mothers had to interpret the PHQ-9 questions, which were in essence double-loaded, asking both about how the mother felt and how frequently she felt this way in the same question. The overall study conclusion is that the nurses are able to integrate maternal depression screening and counseling in their routine work, but most likely require more training and ongoing support, as well as tool adaptation to do it with quality.
We'd like to now invite you all to join us for some brief discussion time in breakout rooms with each of the presenters to discuss what are the biggest challenges and the opportunities for integrating mental health services into your work with caregivers. So our facilitator will divide us into 3 groups, and you'll be randomly assigned with one of the presentations. Welcome back, everyone. I think we just have maybe 3 minutes that we can use to hear from some of the groups if there were any highlights from these breakout sessions, any of your biggest challenges or opportunities for integrating mental health, or other thoughts that you have. Feel free to just unmute yourself, or if you are the facilitator and want to summarize for the group.
So I don't know if anybody from our group wants to jump in, group number 3. Feel free to do that.
Well, someone in our group brought up the issue of reaching adolescent moms and needing to think about the best ways of reaching them. So that's a key aim, I think, for everyone now. And for my own experience discussing in our group, was describing helping providers who've been trained in mental health and psychosocial support to pivot toward postpartum women and not forget that they are a group that's readily available to screen and then to support.
Thanks, that's important.
This is Arcano Aaron. I do see some of the challenge really related to some of the social norm around mental health. And there are so many beliefs, and that leads to discrimination against anyone with the mental health that actually can be an hindrance for any kind of effort that we do with mental health, whether it is with adults or children in the community. I think close look at the social norm and how that drives the belief about mental health, what it is associated with. Sorry, it's early morning from here. But the other thing is really what I see is the early detection is a major problem for kids, for example, even just like in some of the high income countries like US. Most of the providers, they use the observational method to see whether kids are having mental healthy mental development or not when they assess that. So that is mostly observational, and standard tools are not used. That observation, just like I said, about 71% of providers use the observation to identify whether kids are developing some sort of mental health issue or not. That only identified 30% of kids. And then the huge part, the huge part of kids that are going through healthcare, pass undetected. So because of not using that standard tools to assess whether kids are having some mental health development or not. And then they get to the school before no one detects. That is, in some cases, it can be too late. I don't know how much other providers in another country, I don't know really. I've been in another country for a long time, but I don't really know how other providers are using some of the standard healthy mental development, just like the age and the stage question or the bright future kind of question used to identify kids that are developing some mental health issues. So that I think the two are the screening, early screening, and then the cultural social norm around mental health can be a major barrier.
Thanks, Halpana. Janine brought up a good point about how do we address this with donors, and our group was also talking about the importance of adding measurement. I think those are two key issues as well. I know we're running out of time.
Yeah, I put it down there real quick that ask your donors. It is being funded under a number of new areas. Paul Bolton's the head of USAID's mental health work now. If your donor's hesitant, consider a pilot study. Just saying, we're not going to do it with everyone, but then if you have really good results, then you could push for it like at midterm and scaling or something.
Definitely.
Well, thank you so much. I know there's still a lot of things that people want to say, but I just wanted to thank our presenters so much and all of our participants for such a rich and insightful discussion on exploring the impact of maternal mental health and its impact on child health and well-being. We are going to transition now to our second presentation of this concurrent session. So I'd like to introduce a few different people from a few organizations that are going to be discussing Pandemic Pivot, Innovative Approaches to Promote Youth Wellbeing Amidst COVID-19. And so to present that, we have Anita Shankar and Anne Wahinya from Global Trauma Project. We have Ephraim Bukele from IRC-MED. And we also have Darren Collins from Project Hand Up. And so I believe Darren's going to be sharing the slides. So please feel free to begin when you can.
Great, good morning. Darren, are the slides shared yet? Not on my screen.
No, I don't have screen sharing access yet.
Oh.
Just a moment.
Well, I can start with the intro then, because it all works. Good morning. So there's going to be a quote on our slide number 1. The pessimist complains about the wind, the optimist expects it to change, and the realist adjusts the sails. So good morning from my car, because I do not have internet or power at home. When we devised this session over 2 months ago, we thought, we have pivoted enough, and there are 3 great organizations who are innovating approaches. We had no idea that 2 and 3 months later, we would be maneuvering on a daily and sometimes hourly basis around changing and challenging conditions. So I'm so excited to introduce you today to 3 organizations who have kept their eyes on the prize of unlocking the potential of child and adolescent mental health while pivoting their processes. So really rising to meet the situation. We have Darren Collins. Oh, great, and your slide is up. So my name is Anita Shankar with the Global Trauma Project. We will hear from Darren from Project Hand Up, Ephraim from IRC-MED, and my colleague Anne from Global Trauma Project as well. Each presentation will have approximately 6 minutes, and then we have approximately 10 minutes for question and answers. So Darren, take it away.
Okay. I'm going to start with a video.
Audio is not coming across.
I think that when you share, you might want to also share your audio.
I'm going to have to
Familiar with
narrate.
that? So,
501c3 and
Can you hear me now?
Rotary International.
no, I think that we'll still need to have the audio shared.
There's a box at the very bottom you check to say share computer audio. That'll do it.
So if you hover over the mute box on the bottom left, there are little arrows sticking up. You can use built-in output in internal speakers.
Project Hand Up launched as an American 501c3 and is Rotary International Global Grant back in 2015. And we reached a lot of audiences with HIV and AIDS education, hundreds in fact. We produced a 75-minute entertainment show. And subsequently, we were contracted to do other topics from child safety to conservation. And health, however, remained a passion. Any funds we earned from other programs were put back into health programs. We didn't require a partner organization to put us on the road. We had already done that. We knew what we were doing, and we did it without any direction from other organizations. When our major grant ran out, small organizations and private donors kept us limping along. Our greatest pride was how long we could actually hold attention. 75 minutes was no problem at Kenyan schools at almost any age level. And the adults really love the program. It's a bit of a magic trick. As adults, we tend to put up mental barriers when someone tells us what to do or tells us to change our behavior. But if we assume the message is for someone else, especially for children, we tend to encourage the information. Oh, listen to her. She knows what she's talking about. And thus, the adults laugh along with our program, but also listen very carefully with no blocks or barriers. The key for us was always high production value.
Okay. No, I didn't say your brother has HIV. I was just trying to hypothetically.
Yes, you did. You said, your brother, has HIV, Kumbe, hiyo ndio inafanya hata siwezi kucheza hii game ipo. Malume ni tuateni kama shemesh.
Your brother has HIV. Will you also become infected because he is?
Wait, hadi bro yangu ako na HIV. Tangu lini tena?
No, I didn't say your brother has HIV. I was just trying to.
Yes, you did. You said, your brother, has HIV, Kumbe, hiyo ndio inafanya hata siwezi kucheza hii game ipo. Malume ni tuateni kama shemesh. Lazima nijali bro yangu. Nitaduaje kama bro yangu ako na HIV? Si hata mimi naweza get. Oh my god. Bro yangu kama ako na HIV,
No, listen, Bunny. The good news is HIV doesn't work like that.
And we got popular. We booked a lot of gigs. And suddenly it all stopped. When we got a call from the National Business Compact on Coronavirus, they said, "Can you do a video?" And we said, well, we have never, yeah, we can. And we sent everybody home. We social distanced. We did all the right things. We stopped using public transport and carefully planned our video shoots. We had never done this before, but we do care. We care about our craft a lot. 5 years of trying to make a good live show, it looked pretty well when translated onto camera. We were snapped up by a local TV network, in fact 2, and our health announcements were suddenly reaching several million people per day. Up until then, we were reaching a few thousand people a month, but now it was millions a day. A huge change, and since March we've made 12 videos in 11 languages that are broadcast in Kenya, South Africa, and Somalia, and even showing on social media in Yemen. And we started getting calls, and today we are shooting a new video, like right now. I don't have much time to do this. We're shooting assets to sensitize the country on COVID-19 in the unique context of people living with disability. We're shooting our first puppet doing Kenyan Sign Language and have a visually impaired character and a character in a wheelchair. It's been 5 years of hard work, and for the most part, no one really recognized us. But as soon as we made a video in our garage and it played on TV, now organizations started calling. It's a big change. Take a look at what we made.
What is your question?
May I have a plantain?
Cut, Bali. We need you to ask a question about social distancing, not about plantains.
How about bananas?
No!
Wait, hold on everyone. Bali, as long as you practice proper social distancing, you may behave as you normally do.
I can?
Yes, after all, you are a monkey and monkeys will always want to have bananas. But it's important to remember that right now, you should avoid going and doing unnecessary things.
Like making videos?
Maybe, but as you can see, you and I are keeping 2 meters away from one another.
I know! I can't reach any bananas from here.
And right now in Kenya, we all need to keep our distance from one another to avoid the spread of COVID-19.
The coronavirus is carried into the open air by tiny water droplets which others may breathe in and become ill.
Ask Dr. Pamoja.
Listeners, how do you feel about wearing a mask?
I love it. I hate it.
Alright, great. Everybody loves to wear masks.
That's not exactly what I
Next
say.
question. Should I receive more bananas? Let's go to the phone line.
Bali, wait. I said wait.
Hey,
Bali,
wait,
stop.
hey,
Bali,
no, hey,
sit
hey,
down.
Anyway, how are you doing during all this COVID-19, Maneno?
Mom?
It's no different than any other child.
Yeah.
Mother?
Wash hands, wear mask,
Sure.
maintain space.
Yeah. Oh, sure. Hands, mask, space.
Just wear a mask when you go out.
Cover your nose and chin.
And take care of the children in Shushu.
Babu. You know,
The ones we love the most.
Love the most. That's what I always
That's what
say.
I always
Can
say.
they even hear us?
I don't think so.
If we do those things, we can help take back our world from Corona.
Hands, mask, space. I like it.
Okay, so back to the PowerPoint. Anita, take it away.
And now on to Ephraim. Darren, were you able to download his video?
Yes, I was.
Great.
Let me get it for you.
Back to you. Thanks.
Project Hand Up launched as an American.
Hi, my name is Ephraim Bakala. I am representing Irkmad Media and Mental Health Organization from Addis Ababa, Ethiopia. Very excited to be on this online webinar and conference. And Irkmad is a mental health and media company. We've been doing a lot of awareness about mental health and also other related issues, psychosocial issues for the past 10 years. And we were not expecting COVID to happen last year, and it happened to, and it was not only for us, but it was for everyone in the world. And one of the things we've been doing was child-friendly spaces in the school. When we say child-friendly spaces, it's related to mental health, mainly on mental health issues. So we witnessed that children and young people in the school are exposed to mental health issues. So we decided to come up with a project, and we called the project Seed Wellness, to bring wellness and mental wellness at the seed level. So we went to the school and we tried to understand what's the problem. And this happened last year before COVID. And what we found out is that there is a lose between the parents, teachers, and also the school counselors. So we put these three stakeholders in one place, and we tried to understand what's happening in the school setup, especially related to children and adolescent mental health. So parents are complaining about their children. Students, school counselors are also complaining about student behavior. And teachers are also complaining about the students' mental health. So they all have issues, but they didn't get the space, the stage to talk about these issues. So we decided, okay, how about we bring all these stakeholders into one place and bring mental health awareness. So we started with mental health awareness, then we continued with a manual for children and young people to express their fear, their trauma, and also their issues in the school setup. So that became a program, and we call it Seed Wellness. And because of COVID, we couldn't proceed. Then for 3 months, we have been teaching these 3 stakeholders about the issue. Then once school has been reopened like this year, we started like providing the service in 2 schools, and it's going really great. And we've seen a lot of change. We've seen a lot of challenge of mental health among students and adolescents, but also these 3 stakeholders are working together to address these issues. So this has been a great experience for us, and we are also doing more research to understand what's going on the ground so that we can populate our service in a better manner. So with that, I'll give it to the next speaker. Thank you very much.
Great, thank you. And hopefully Ephraim is on the line. He was in and then he was out, so we'll be able to speak briefly at the end. Now I'd like to pass it along to my colleague, Anne Wahinia in Kenya. Darren, can you pull up the PowerPoint, please?
Yes.
Anne, are you there?
Yes, I'm here. Hello, everyone. Global Trauma Project is actually a mental health organization. We build the capacity of community care providers to provide trauma-informed programming in a manner that is accessible, culturally relevant, and also that has been shown to provide significant impact. We are a capacity building organization. So what we do is to train, mentor, and certify trusted community members to facilitate trauma-informed programming. So pre-pandemic, we conducted what we call a girl roster exercise, where we were looking for girls who are off track, meaning that these are girls who have been left out of the care system and are having serious trauma and compounded stress issues. And what we found is that we found 43% of girls where we work are extremely off track. We had over 50% of girls at least 2 years behind in their grade of schooling. But also we did find 50% of girls who had not transitioned to secondary school and were having a lot of compounded stress. And then when the pandemic hit, our work was interrupted. We decided to do a mental health assessment in 608 households. And what we found out is that 91% of people knew someone who was stressed and needed more support. 56% did not know of any mental health providers within their community. But apart from that, we found 91% of respondents who reported experiencing very high levels of psychosocial stress that they needed additional support to cope. We also found around 58% of community respondents who say they would go to a mental health provider for help if the mental health services existed, but they had no knowledge of such services. Next slide. So at GTP, we use the trauma-informed community empowerment framework, which focuses on personal and holistic well-being. It has 5 components of safety, regulation, connection, identity, empowerment, joy, and basically community care. So looking at on the issues of safety, we look at it holistically in terms of personal safety, but also in the community. But what we did with the ties at the moment when COVID hit was to realize that all these elements of safety, regulation, there was a lot of emotional dysregulation going on. The connections were all, limited due to social isolation. People really lost a lot of identity because, they didn't know who to reach out to. They were going through a crisis, and of course, people's joy went down, and most of the, community participants, especially our target group, adolescent girls and young women, experienced surging cases of GBV, and they felt they were not empowered. Next slide. So we have contextualized the trauma-informed community empowerment framework in East Africa, in Somalia, South Sudan, and Kenya. And TICE has been shown to have very significant impact. In South Sudan, after 3 weeks of the trauma-informed community empowerment training, participants were able to reduce their critical heart stress from 58% to 28%, and emotional dysregulation from 90% to 70%. Once we contextualize TICE, we have now trained a cadre of 24 community-based mentors who will be working with identified adolescent girls and young women who are off track. These are girls who are out of school or in school, they are married, have a child, they either live with one or no parents, but they are also prone to having mental health issues, post-traumatic stress, depression, or have suicidal thoughts, and also are most at risk of IPV or domestic violence or HIV or other risk factors. In addition to that, we are in the process of establishing safe spaces for these adolescent girls and young women. For now, what we have done, we have a community-based mental wellness center. You can see it down there. We are just in the process of setting that up. And we will be providing mental health, community-based mental health services. And the safe spaces, we have the mentors who will actually, for the first time, provide trauma-informed programming content, and we are looking forward to see how that will work out. Yes, I end there. Back to you, Anita.
Great, thank you. Right on time. Ephraim, are you on the line? And would you like to say anything? Can't tell if he's here. No, I think he left. But so now, questions from the audience. You've heard from 3 different presentations. How does it relate to what you're doing? And how have you been pivoting also in relation to COVID-19? I would love to hear. Feel free to unmute yourself or write in the chat as well.
This is a question for Darren. How do we access your the videos, those related to the COVID and these kids?
I put my website link in there, and I think from there is the YouTube channel. But if you look up YouTube Project Hand Up, that may be helpful. I'll put a link right away, actually.
Thank you.
That has about 9 or 10.
Darren, can you also speak about how you've translated it to different languages and the importance of that, as well as radio?
Yeah, but the studies here show that vernacular, of course, is going to have the greatest impact than any other language outside of Nairobi, and also radio actually has a greater impact than video does, and so we immediately began to hire translators, interpreters, but we use stand-up comedians almost entirely to do translations. We find they're a little more in touch with the current language. So we find guys and we basically say, make sure your grandmother loves this translation. And so the guys in Nairobi do their vernacular stand-up comedy take on everything. And then we have those guys that love really young actors come in and do the parts. And then the beauty with puppetry is it's easier to dub than humans, and it's less costly to redub than animation. So we have the opportunity to change language, and it doesn't look, like a translated soap opera from another country or a Godzilla film. Yeah.
I just wanted to add that I really loved the diversity in your presentations. Obviously, using play and comedy is definitely a way to appeal to people, and also having a trauma-informed aspect to your work, which kind of puts the human first and not their behaviors or whatever they're struggling with, but you just, treat them and work with them mindfully. I thought it was a great presentation overall from all of you. So thank you.
Yeah, thank you. And especially when we're talking about global health practitioners, our whole model starts with personal well-being, but from a liberation point of view, that global health practitioners need the support and the resources and the opportunities and the funding to take care of themselves so that they can do better work. So it really is the heart of our trauma-informed community empowerment framework, and is currently in a training right now. And once again, in theory, training about outside issues, but there were issues even within the trainings that the framework applied to. And that's the benefit of having a flexible framework. So we don't tell people how to go about trauma-informed initiatives. We work with them to learn the context, the strengths, and the gaps, and then give them a common language so they can proceed with community-led initiatives. Are there any other questions from the group?
Yeah, sure. For Darren, I was just wondering what sort of evaluation data you have. It looks like a very engaging, wonderful work, both for mass media and local groups. But we've seen other really exciting work that they weren't able to see as many results when they actually measured it. So I wonder, where are you in terms of showing those measurements?
So measurements are interesting, and I think people in the arts area are always dealing with how to measure it, because when you're doing a hearts and minds campaign about stigma or respect and gender equity and equality, it's sort of measured in generations, and so and not like in a before after thing. But for an A/B test, we'll do like memorization, like what did the audience remember, and like 30 days later or a year later or whatever. And it's okay. I think we still have to work on designing our tests more better, and speaking more better. And one of the other things we can do, though, is what we do as performers is we gauge. The audience is immediate in telling us whether or not they're enjoying it or paying attention. And so we look at other campaigns and say, how long does the billboard campaign hold someone's attention as opposed to our 75-minute program or our video? Or are they watching all the way through? So attention span is sort of the way we as artists sort of define whether or not it's working. And then, of course, I don't know, you're touching on something that we all really struggle with. And I would actually
with that. We've got some great thinkers on that. And also BBC Media did some great work in Burundi around measuring the results of their mass media work. So that might be a good contact.
You said BBC and what?
Sorry, BBC Media, I think is the name of the group.
Yes, in addition to that, we use the heart rate variability assessment measure, that just is able to measure and give us whether, someone HRV is high or low. That's one of the other measures we use. And then we have a couple of other measures that have been contextualized based on what we found in each community. Sometimes we have been using the HTQ, the brief resilience scale, but mainly the baseline information, we use the heart rate variability assessment.
We have
great, and I think we're yeah.
Sorry, Anita. We do have some comments in the chat. Mary DeCoster has some thoughts for Darren and Project Hand Up. Bukola says the issues discussed here are so relevant to my experience as a teacher. Mental health is really important in schools and should be taken seriously. Thank you to the facilitators. I definitely felt that way listening to Ephraim's presentation about incorporating those safe spaces in school. Awesome. We're just getting really great feedback for your presentations. So thank you so much again to our presenters. If anybody has anything that they want to share, quickly feel free to do so while we're still here. But otherwise, I think that's it. Our next presentations will be the marketplace. So please feel free. Actually, let me just make sure that if there are one. Okay, perfect. So we do have time for more questions. I just got a ping that there are more time. So please feel free to ask away, or any thoughts that we want to share.
Darren, can you put up the last slide that just has contact information? There was someone who wanted to learn more about the heart rate variability, which is a measure of critical heart stress. So the body's ability to handle stress. And what we want to be able to do literally is after that. But when we've experienced a lot of trauma and compounded stress, and once again, this goes back to our work of global health practitioners, because it's not just issues out there, we're affected by it as well. So to give you an example, in South Sudan, when we did a nationwide trauma healing program there with local providers, we measured over almost about 300 providers who were between the ages of 20 and 40, average age of 35 years. Their critical heart stress was that of 90-year-olds, 90. That's how much stress and trauma can wear down on our bodies. But through our program, having the opportunity for contextualized, comprehensive, and effective mental health supports, they were able to reduce their critical heart stress within 3 weeks, and even 1 year after our program, it continued to improve. And the fact that it continued to improve after our program without us makes me particularly proud, because people think that we heal them and they say, oh my gosh, thank you, but it's really not. We give people the opportunity to absorb the information and integrate it and take care of their own.
Thank you so much, Anita, and to all of our presenters again. I just dropped a link for the agenda in our chat box. We're moving into a quick 15-minute break, but please visit the poster section in the exhibition hall. And then at 10:15, we pick up again with our marketplace rooms. So thank you all so much, and please enjoy the rest of the conference. I'll see you at closing remarks.